When sperm enters the female reproductive system, it travels up to the fallopian tubes, searching for an egg to fertilize. This is the start of potential conception. Sperm penetrates the outer layer of the egg. Only one sperm can successfully break through this layer, and once it does, the surface of the egg changes immediately to prevent any other sperm from entering. When the sperm enters the egg, the tail is no longer needed and disintegrates. The head of the sperm fuses with the egg. The sperm's nucleus, which carries the father's DNA, fuses with the egg's nucleus, which contains the mother's DNA. The genetic material from both mother and father combines to create a complete set of 46 chromosomes, half of which are inherited from each parent. This single cell, known as a zygote, is the first cell of the developing embryo. It carries all the genetic instructions necessary to form a new individual. The zygote begins a rapid process of cell division. It divides into 2 cells, then 4, then 8, forming a small, growing ball of cells. As the cells are dividing, gentle muscle contractions in the tube's walls and tiny hair-like structures called cilia propel the zygote along the fallopian tube toward the uterus. This journey typically takes about 3 to 5 days. By the time the zygote reaches about 16 to 32 cells, it becomes what's called a morilla, which looks like a tiny cluster of cells. By 4 days of development, the morilla begins to absorb fluid, and a large cavity called the blastocell, forms within it. The blastocyst has an outer layer of cells that will eventually form the placenta and an inner group of cells that will develop into the baby. When the blastocyst finally reaches the uterus by day 5, it hatches out of its outer membrane. The blastocyst attaches itself to the uterine lining, known as the endometrium. This process is called implantation. This allows the blastocyst to attach to the uterine wall, enabling it to obtain nutrients and oxygen from the mother's blood supply, supporting its continued growth and development. In rare cases, unusual events can occur during the early stages of cell division. The developing cell splits into 2 distinct groups, each with the same complete set of DNA from the original fertilized egg. These 2 groups of cells continue to divide independently, and each one will eventually develop into a baby. The exact mechanism that triggers the splitting of a zygote is not yet fully understood. Potential genetic factors, along with certain environmental influences, such as specific fertility treatments, may affect the likelihood of this occurrence. Identical twins can form at any point from the first couple of days after fertilization up to about 2 weeks. The split's timing determines how much the twins share within the womb. The earliest separation is believed to occur at the 2-cell stage, in which 2 separate zygotes develop. This early split leads to each twin developing separately, with its own amniotic sac and placenta. These are called dichorionic D-amniotic twins. Each twin has its own environment within the womb. This is the most common and lowest risk scenario for identical twins. If the split occurs a bit later, 4 to 8 days after fertilization, usually after the morilla has developed into a blastocyst. These are called monochorionic D-amniotic twins, meaning they share one placenta but each has its own amniotic sac. This setup occurs in most identical twin pregnancies and results in the twins having a shared blood supply but separate pockets in the uterus. Sharing a placenta can result in complications like twin-to-twin transfusion syndrome, TTTS. In this condition, one twin receives most of the blood flow, and flow to the other is compromised. As a result, one twin is larger than the other. The outcome is poor, with the death of both twins occurring in 50% to 70% of cases. However, because each twin has its own amniotic sac, they are protected from becoming entangled with each other's umbilical cords, which reduces some of the associated risks. If the split occurs after the blastocyst has fully implanted in the uterus, 8 to 13 days after fertilization, it is known as monochorionic, monoamniotic twins. This arrangement is more complex because the twins share not only a placenta and blood supply and the high risk of TTTS syndrome, but they also share the amniotic sac. This shared amniotic sac increases the risk of umbilical cord entanglement as the cords have more opportunities to cross paths. In extremely rare cases, the split occurs even later, between day 13 and day 15. Resulting in twins who are conjoined because they did not entirely separate. Conjoined twins split too late for each twin to develop entirely separate bodies and share some organs or body parts. They face significant challenges due to their unique condition. Many of them are stillborn. Of those who survive, around 35% only live a few days after birth due to complex health issues. Those who survive often face complex health and medical challenges. These slight variations in the timing of the split influence each twin's prenatal environment, but the essential process remains the same. One fertilized egg or zygote splits, resulting in 2 genetically identical babies. Typically, a woman releases a single egg during ovulation. However, sometimes, due to hormonal influences, 2 eggs can mature and be released. This is called hyperovulation. As women age, particularly between 35 to 40, the likelihood of releasing multiple eggs increases. As women age, the number of eggs remaining in the ovaries begin to decline. In response to this decrease, the body produces higher levels of follicle-stimulating hormone, FSH, to more vigorously stimulate the remaining follicles. Elevated FSH levels stimulate more follicles, allowing 2 eggs to be released in the same cycle. Women with a family history of fraternal twins are more likely to release multiple eggs. Non-identical twins are more common in some ethnic groups, with the highest rate among Nigerians and the lowest among Japanese. IVF can increase the chance of twins, as more than one embryo may be transferred. So, multiple births are more common than they were in the past due to the advancing average age of mothers and the associated rise in assisted reproductive techniques. These two eggs may come from the same ovary or one from each ovary. Both eggs are released around the same time in the menstrual cycle and travel through the fallopian tubes to await fertilization. If ejaculation occurs during this time frame, both eggs can be fertilized by different sperm cells, leading to the development of fraternal twins. Since fraternal twins come from two separate fertilization events, each embryo develops independently with its own genetic makeup and cell structure. After fertilization, each egg-sperm combination forms a zygote, a single-cell embryo. These zygotes undergo a series of rapid cell divisions as they travel down the fallopian tube toward the uterus. By the time they reach the uterus, the blastocysts are ready to implant into the endometrial lining. Each twin implants separately in the uterus. After implantation, each embryo develops a placenta, which provides nutrients and oxygen from the mother's bloodstream. The embryo also forms its own amniotic sac, filled with fluid to cushion and protect it. Fraternal twins are dichorionic diamniotic, DD, which is the safest type of twin pregnancy. The twins are in separate fluid-filled spaces, which reduces risks like umbilical cord entanglement, a concern in some identical twin pregnancies. Unlike fraternal twins, identical twins come from a single fertilized egg that splits into two. This is completely random and not influenced by genetics, hormones, or age. Fraternal twins are more common, 70%, than identical twins, 30%. Because fraternal twins are genetically unique, they may look different, be of different sexes, and have different traits. They share half their genomes, just like any other siblings. A full-term pregnancy for a single baby lasts about 40 weeks, but when a woman is carrying twins, the timeline changes. Up to 50% of women with a twin pregnancy will reach 37 weeks gestation and beyond. The risk of stillbirth, neonatal death, and neonatal morbidity associated with twin pregnancies has been demonstrated to increase with advancing gestational age. Elective birth at 37 weeks gestation may be a safe and effective way to reduce perinatal mortality and morbidity in twins. Twins or more are also at higher risk of preterm birth. Nearly 7 out of 10 twin pregnancies result in premature birth and often have lower birth weights than singleton babies. Many weigh less than 2.5 kilograms at birth, which is less than the average birth weight of single infants, 3.4 kilograms. However, with proper medical care and monitoring, most twins grow and develop just as well as their singleton counterparts, catch up in growth, and reach critical developmental milestones, especially with the proper support in those crucial early months. The uterus is one of the most unique organs in the body. Before pregnancy, it is about the size of a lemon, measuring 7 to 8 centimeters in length and holding approximately 10 milliliters of fluid. At full term, 40 weeks, in a singleton pregnancy, the uterus expands dramatically. It can measure 35 to 40 centimeters long and hold about 5 liters of fluid, the fetus, and the placenta. In a twin pregnancy, the uterus stretches even further to accommodate both fetuses. It may hold 6 to 10 liters or more of fluid, placentas, and the growing twins. As the uterus expands, the mother may experience increased discomfort, increasing shortness of breath, acid reflux, and difficulty sleeping. Hormonal changes add to the challenge, combined with extreme fatigue, limited mobility, and fear of labor. These factors can take a significant toll on the mother's mental well-being. Additionally, the risk of gestational hypertension and gestational diabetes increases. Braxton Hicks contractions become more frequent and may be mistaken for real labor. Due to the higher risk of preterm labor in twin pregnancies, doctors closely monitor for contractions, cervical changes, and signs of early labor, sometimes requiring hospitalization. In the weeks leading up to delivery, the fetuses gain weight rapidly, though they may still be smaller than singleton fetuses. Their lungs continue developing as they practice breathing movements. The lungs are typically fully developed by 37 weeks of gestation, which enables independent breathing. However, more than half of twin pregnancies result in preterm birth before 37 weeks. In such cases, newborns may require NICU support to assist with breathing until their lungs fully develop. By weeks 37 to 38, the pregnancy reaches full term for twins. At this stage, induction or a scheduled C-section is often recommended, as carrying twins beyond 38 weeks increases the risk of stillbirth and placental insufficiency. Momo twins should always be delivered by cesarean section to avoid umbilical cord complications. About 60 to 75% of twins are born by C-section, but vaginal delivery is still possible in certain cases. Vaginal delivery of both twins are the most desirable outcome. However, the doctor may recommend a C-section if the first baby is lying on its feet, knees, buttocks first, or sideways, a low-lying or shared placenta, or a difficult delivery with a single baby before. In preparation for birth, the doctor assesses the fetus's situation via ultrasound. If both twins are head down, vertex-vertex, vaginal delivery is possible. However, if the first twin, called twin A, is in a head-down position, and the second twin, twin B, is breech or transverse, vaginal birth may still be possible under certain circumstances. For all women with twin pregnancies attempting labor, regional anesthesia, epidural, is recommended, as it allows for the breech extraction of the second twin, a procedure that is difficult to perform without adequate anesthesia. Labor in twin pregnancies starts the same way as in single pregnancies, with contractions. The uterus begins tightening regularly, the contractions occurring every 5 to 10 minutes and lasting at least 30 to 60 seconds. The first amniotic sac usually breaks on its own. If only one sac ruptures, labor can still progress, and the second sac may break later. During labor, the mother's body releases a high amount of various hormones. Oxytocin stimulates contractions. Beta endorphins help relieve pain. Relaxin and estrogen make the pelvic ligaments, cervix, and vaginal tissues more flexible. After the water breaks, contractions intensify, helping push the baby down into the birth canal. the cervix gradually opens from 0 centimeters to 10 centimeters, allowing the baby's head to pass through. Because the uterus is already stretched, twin labor has a significantly shorter first stage than single births. Once the cervix reaches 10 centimeters dilation, it's time to push. The vaginal walls and birth canal are elastic, designed to stretch and expand without tearing, allowing the baby to pass through. The baby's skull is soft and can change shape slightly to fit through the birth canal. This is called molding, and it helps the head pass through more easily. Once the widest part of the head passes, the hardest part is over. The baby's head rotates slightly to help the shoulders fit through the birth canal. The doctor gently guides the baby's shoulders out, followed by the rest of the body. Once the baby's head and body are out, the doctor clears the airway and the baby takes the first breath. Once twin A is delivered, the doctor clamps and cuts the umbilical cord, but does not yet deliver the placenta, as twin B is still inside. After twin A's birth, doctors closely monitor twin B's position using ultrasound. With the extra space available, twin B may shift positions within the uterus. If twin B turns sideways, transverse, or breech, the doctor may attempt internal podalic version, IPV, in which the doctor inserts a hand inside the uterus to grasp the baby's feet and turn it into a breech position for delivery. This procedure requires high skill from the medical professional. If twin B stays head down, vertex, a normal vaginal birth can continue. The mother continues pushing. Twin B's delivery is usually easier than twin A's because the birth canal is already open. It is usually delivered within 10 to 30 minutes. Once twin B is delivered, the uterus continues to contract to help detach and expel the placentas. These contractions are usually weaker than those during birth. The doctor may apply gentle pressure on the mother's abdomen to push the placenta out. If each twin had their own placenta, dichorionic twins, 2 separate placentas will be delivered. If the twins shared one placenta, monochorionic twins, 1 placenta will be delivered. The doctor checks the placentas to ensure no pieces are left inside the uterus. Immediately after birth, each twin is checked for breathing, heart rate, weight, length, and head circumference. The babies are placed skin to skin on the mother's chest to promote bonding. If the babies are ready, the first breastfeeding session may begin. Twin mothers produce more milk, but establishing a feeding routine takes time and practice. Rest, hydration, and a diet rich in iron, protein, and vitamins are essential for maintaining the milk supply. After delivering twins and their placentas, the mother's body goes through a recovery process and the uterus starts contracting back to its normal size. This process, called involution, may cause mild cramping, especially during breastfeeding. Heavy bleeding, called lochia, occurs for the first 1 to 2 weeks. It then lightens and lasts 4 to 6 weeks. Clots are normal, but large clots or heavy bleeding should be reported to a doctor. Recovery may take longer due to higher blood loss and the physical demands of carrying twins. A twin birth is a major event for both parents, but the mother undergoes significant physical recovery and emotional changes. A supportive father or partner plays a crucial role in her healing process, both physically and mentally. Hormonal changes can cause mood swings, anxiety, baby blues, or even postpartum depression. It's important to be patient. Encouraging open conversations about how she feels can help her process the transition into motherhood. Let her know she is loved and appreciated for everything she's doing. Taking responsibility with diaper changes, bottle feeding, burping, and soothing. The father's role is not just helping with the babies, but also caring for his wife. Parenthood is a shared journey, and with love, patience, and teamwork, both parents can support each other and embrace the challenges of raising twins together.